Welcome back to the deep dive. Today we are taking a structured, headfirst plunge into, well, one of the most complex yet absolutely critical systems in the human body, the immune system. We're not just talking about how it works when everything's running smoothly, but specifically what happens when our body's defenses, fail or maybe overreact or even lose control entirely.
It really is the command center of defense. And what we've aimed to do for you is synthesize this pretty vast unit of medical knowledge, the pathophysiology, the risks, the diagnostics, and crucially, the collaborative care into a single, hopefully navigable briefing.
Yeah, roadmap.
Exactly. Our mission is to distill these core concepts around immune dysfunction. We sort of group them into three major types of problems.
That's right. We're really dissecting that whole spectrum of immune failure. First up, we've got reduced or inadequate immunity. We'll look at that mainly through HIV and systemic infection. Second, we look at the flip side, excessive or inappropriate immunity. This covers things like hypersensitivity, think allergies, and autoimmunity, like lupus, SLE.
Right. And then finally, we tackle that third category, the one everyone dreads, really. The loss of cellular regulation. That's the mechanism behind cancer development and its management.
So by the time we finish this deep dive, the goal is for you to have a really solid grasp on the priority interventions, the safety alerts, basically everything you need across this entire spectrum of care.
Okay, let's start at the very beginning, the absolute foundation. Chapter 16 really lays out the boundaries of our defense system.
Right.
And immunity, at its core, it hinges on recognition. An antigen, that's basically anything the body sees as non-self that triggers some kind of response.
And the proteins we make in response, those are the antibodies, right, or immunoglobulins, tailor-made to latch onto those specific antigens.
Precisely. But maybe the most fundamental concept here, the thing that stops us from constantly attacking our own tissues, is self-tolerance.
Yeah, that's crucial.
Think of it like the body's own sophisticated biometric scanner. It's this specialized ability of our immune cells to recognize our self-markers, our own cells, and actively not harm them.
So when that scanner malfunctions...
That's when you get the autoimmune disorders we'll definitely talk about later. The system starts attacking itself.
Okay, so the defense system isn't just one thing, it's layered. For complete protection, we need all three pillars of protection, as we might call them, working optimally.
That's a good way to put it. First pillar, inflammation. This is your immediate, nonspecific, rapid response. It kicks in the second there's any tissue damage. Bang.
Quick and dirty, basically.
Pretty much. Second pillar, antibody-mediated immunity, or AMI, sometimes called humoral immunity. This one relies on the B lymphocytes,
Their main job.
making those very specific antibodies that float around in body fluids, hence humoral. This is the part of the system that really remembers past invaders.
Okay, so inflammation is fast, AMI is specific, and remembers. What's the third?
The third is cell-mediated immunity, or CMI. Think of this as the Special Forces unit. It uses T lymphocytes and also natural killer, or NK, cells.
And their job?
Their job is direct action, patrolling and executing. They destroy non-self cells directly, things like virally infected cells, cancer cells, even transplanted cells.
Got it. So three distinct but interconnected pillars. Now let's zoom in on the actual cells doing the work, the leukocytes, the white blood cells, starting with the inflammation guys.
Right, the neutrophils. These are your frontline troops. They make up the biggest chunk of your WBCs, like 55 to 70%. And they are rapid response phagocytes. They engulf and destroy pathogens fast.
Okay, phagocytes, cell eaters. Now, here's where it gets clinically interesting, right? When there's a really bad infection, maybe sepsis, and things are ramping up quickly.
Yeah, the bone marrow just can't keep up producing mature, effective neutrophils. So it starts pushing out the immature ones, the banned neutrophils.
And that leads to?
What we call a left shift, or bandemia. And you really need to understand this isn't just some lab value curiosity.
No, it's a big red flag.
It's a critical warning sign. It tells you the body is so overwhelmed, it's sending out rookies, basically. These immature cells, they're not very good at phagocytosis. Seeing a left shift almost always points to a severe, ongoing bacterial infection that needs immediate attention.
Okay, so neutrophils are the sprinters. Who are the marathon runners?
That would be the macrophages. These guys have long lifespans, they're incredibly effective phagocytes, But critically, they also perform antigen presentation,
Meaning?
meaning they engulf the invader, process it, and then essentially hold up a wanted poster, a piece of the antigen to the helper T cells.
Hmm.
This is the crucial step that activates that precise, specific adaptive immune response we talked about with AMI and CMI.
They bridge the gap between the initial response and the targeted one.
Perfectly put. Then we also have the cells that cause all those dramatic physical signs of inflammation and allergies, the basophils and the mast
Those are
cells.
the ones that release histamine.
Exactly. When they get activated, they degranulate, they pop open and release these potent vasoactive amines, histamine, heparin, kinins. These chemicals cause blood vessels to dilate and become leaky.
And that leakiness is what causes the redness, the heat, the swelling, the classic signs.
Precisely. And one more specialized cell type to mention, eosinophils.
Okay, what's their niche?
If you see a big spike in eosinophilia, it's a major diagnostic clue for two specific things. Parasitic infections, especially worms, helminths.
Right, like that NCLEX question mentions.
Exactly. And also, of course, allergic reactions.
Got it. So with all these important cells, we absolutely have to talk about how aging affects the system. This often gets missed. But physiologically, getting older means a pretty significant decline in our defense capabilities.
Yeah, this is clinically huge. You see reduced numbers of neutrophils and macrophages, and their function declines. That immediate innate inflammatory response just isn't as robust in older adults.
And the adaptive side.
That slows down too. B cells are slower to get sensitized and churn out new antibodies. T cell function decreases. Memory cells, they take much longer to respond when they see an old enemy again.
Which is why things like flu shots and pneumonia vaccines are so important for older adults. They need those regular boosters because their immune memory is sluggish.
Absolutely. But here's the major clinical takeaway, the thing you must remember. Because this whole defense system is somewhat muted, older adults might not show those classic, reliable signs of infection.
Like fever.
Exactly. They might not mount a fever at all, or they might only show a very delayed or even absent rise in their white blood cell count, even if they have severe bacterial sepsis.
So that standard definition of fever might not apply.
Right. Their baseline temperature might be lower anyway, so maybe a temperature of just 99 degrees Fahrenheit or 37.2 degrees C could actually be significant fever for an older person. Clinicians have to look for other signs, often non-specific neurological changes.
Like confusion.
Acute confusion, yeah. Or maybe new onset restlessness, or just a sudden change in their functional status. Sometimes that's all you'll see signaling a life-threatening infection. You can't just wait for a high temp and chills.
Wow, okay. And there was one more surprising thing about aging and immunity.
Autoimmunity.
Yeah, that's a twist. Along with the general decline, the physiological changes of aging also include an increase in circulating autoantibodies. It's like that biometric scanner, that self-tolerance mechanism, starts to glitch more often.
Raising the risk for
Developing new autoimmune diseases later in life.
Mhm.
So decreased defense against invaders, but increased risk of attacking self. It's a tough combination.
Okay, so we've got these three pillars, inflammation, AMI, CMI, working hopefully perfectly. But what happens when one specific pathogen pulls off, like a surgical strike, and takes out the command center of the whole adaptive system?
Well, that brings us squarely into our first major category of failure.
Reduced immunity.
And the prime example here is HIV disease. #tag A. Concepts of care for patients with HIV disease, Chapter 17. Pathophysiologically, HIV is, well, it's incredibly clever, unfortunately. It's a retrovirus, and it specifically targets and destroys CD4 plus T cells.
The very cells that orchestrate the adaptive immune response.
Exactly. And being a retrovirus means it carries its genetic info as RNA, not DNA. So it has to convert that RNA into DNA to hijack the host cell.
Right. Think of the virus like a spy trying to infiltrate your headquarters and set up its own factory. It needs a few key tools. And luckily for us, each tool is a potential target for our drugs.
Tool number 1.
It's blueprint copier, an enzyme called reverse transcriptase, or RT. This is what converts the viral RNA into DNA.
And we block that with?
Two main drug classes, NRTIs, nucleoside reverse transcriptase inhibitors, and NNRTIs, the non-nucleoside ones. They basically jam up that copier.
Okay, copier jammed. What's next for the virus?
Now it has viral DNA, but it needs to splice that into the host cell's own DNA, like permanently integrate it. The enzyme that does this, the key to get into the host genome, is integrase.
And we have drugs for that too.
Yep, the integrase inhibitors, they block that step. So the viral DNA can't become part of the host's blueprint.
Okay. What's the third critical enzyme?
Protease. So after the host cell machinery is tricked into making new viral components, these components come off as long, non-functional protein chains. Protease acts like molecular scissors.
Cutting them into functional pieces.
Exactly. It snips those long chains into the precise functional proteins needed to assemble new infectious virus particles.
So protein inhibitors block the scissors.
Right. If you block protease, the new viruses that get assembled are essentially duds. They can't infect other cells.
And putting these different drug classes together.
That's CAR-ET, combination antiretroviral therapy. It works by hitting these critical replication steps simultaneously, making it much harder for the virus to develop resistance. It controls the virus, keeps the levels down.
Controls but doesn't cure.
That's key.
Absolutely key. It's lifelong therapy. Now, it's also really important to distinguish between just having HIV infection and progressing to AIDS, which is stage HIV-3.
Right. How is AIDS defined? You need one of two things to happen for that diagnosis. Either the CD4 plus T cell count, that crucial commander cell count, drops below 200 cells per cubic millimeter, or the patient develops what's called an AIDS-defining condition. There is a whole list specific opportunistic infections, certain cancers like Kaposi's sarcoma. You can find these listed. Table 17.2 covers many of them.
And immunologically, besides the low CD4 count.
You often see the CD4 plus CD8 plus ratio flip. Normally it's above 2, meaning more helper T cells than cytotoxic T cells. In advanced HIV, it drops below 2, showing the immune system hierarchy is completely disrupted. Low total WBCs are common too.
Okay. So since CART is lifelong and only controls the virus, adherence becomes everything. And that 90% rule is kind of shocking.
It is, and it's non-negotiable. Patients absolutely must take their prescribed CART regimen correctly at least 90% of the time. That means missing no more than, say, 1 dose out of 10 or maybe 3 doses a month for a once-daily regimen.
And the consequence of not hitting that 90%?
Yeah. Drug resistance. The virus mutates, finds ways around the drugs, and the danger here is really twofold. First, if resistance develops to a particular drug or class, those medications are basically lost as treatment options for that patient forever.
Wow.
But second, and this is really ominous, that drug-resistant strain of the virus gets archived in the body's latent reservoirs, places where the virus hides out, like in lymph nodes. It can stay there indefinitely.
And potentially be transmitted to others.
Exactly. So that strict adherence isn't just about the individual patient's health. It's a public health imperative to prevent the spread of resistant HIV. Education on this is paramount.
Absolutely. Let's talk transmission and prevention. Sexual transmission risk goes way up with a detectable viral load, right?
Definitely. Which is why CART itself is a prevention strategy. Undetectable equals untransmittable, or U. We also know drug therapy during pregnancy has dramatically cut the risk of passing HIV to the baby from about 25% down to less than 8%.
Okay, let's talk prevention strategies.
All right.
Pre or P first. Pre-exposure prophylaxis.
Right. This is for people who are at high risk but are confirmed HIV negative. They take specific antiretroviral drugs daily, like Truvada or Descovy, to prevent getting infected if they are exposed.
But there are strict rules around pre-PP.
Absolutely. There's a crucial drug alert here. Before starting pre-P, you need documented proof of HIV negative status using a sensitive fourth-generation test. And while on pre-P, patients need regular HIV testing every 3 months, plus checks on kidney and liver function.
And importantly,
Pre-P does not replace safer sex practices like condoms. It's an added layer of protection, but adherence is key, and those regular checkups are vital.
okay, what about after a potential exposure, like a healthcare worker getting a needle stick? That's PEP.
Post-exposure prophylaxis. If an occupational exposure happens, like a Sharps injury, immediate action is critical. First, wash the wound thoroughly with soap and water for a full minute. Then contact occupational health or the emergency department immediately.
Speed is critical for PP.
Absolutely. PPP, which involves taking a full course of CART, ideally needs to be started within 2 hours of the exposure, and definitely no later than 36 hours. Waiting longer significantly reduces its effectiveness.
And how long is the course?
It's typically 28 days of CART, followed by HIV testing at baseline, and then again at 1, 3, and 6 months after the exposure to confirm they remain negative.
Okay. Now, because the core problem in HIV is that reduced immunity, patients are highly vulnerable to opportunistic infections, OEs.
Right. These are infections caused by microbes that are normally present in the environment or even part of our own normal body flora. But they only cause disease when the immune system is weakened.
So we need to know the big ones and what to look for. Pulmonary seems major.
Yes, the biggest lung threat is often pneumocystis jirovecii pneumonia, or PCP. Clinically, you need to assess for shortness of breath, maybe tachypnea, fast breathing, and often a persistent nagging dry cough. Fever might be low grade or absent.
Okay, PCP. What else is a major concern?
Tuberculosis, TB. The risk is very high. Maybe 2 to 10% of people with AIDS develop TB. And this brings up a really critical clinical concept: anergy.
Anergy, meaning?
Meaning that in patients with very low CD4 counts, say below 200, their immune system is so suppressed they might not be able to mount any immune response to the standard PPD tuberculin skin test.
So a negative PPD test doesn't rule out TB in these patients.
Not at all. It can be falsely negative because of anergy. That's why you can't rely solely on the skin test. You need other diagnostics like sputum tests using nucleic acid amplification testing, NAT, which directly detects the TB organism's genetic material.
And the safety implications.
Huge. Any patient with HIV who presents with symptoms suggestive of TB cough, fever, night sweats, weight loss must be placed on airborne precautions immediately in an AIR room until TB is definitively ruled out by those more sensitive tests. You can't wait for the PPD result.
Okay, what about viral OIs?
We see a lot of issues with viruses that normally stay dormant. Cytomegalovirus, CMV, can cause retinitis, leading to vision loss or severe diarrhea. Herpes simplex virus, HSV, can cause persistent, painful sores. And varicella zoster virus, VZV, can reactivate as shingles, causing intense pain along nerve pathways.
Got it. Beyond infections, are there other major complications to watch for?
Yes, 2 big ones. First is IRIS, the immune reconstitution inflammatory syndrome.
That sounds paradoxical.
It is. It happens when a patient starts CART, their CD4 count starts to recover quickly, and the newly strengthening immune system suddenly sees and overreacts to underlying, previously unrecognized opportunistic infections. Things actually seem to get worse temporarily.
How's that managed?
Usually with corticosteroids to calm down that excessive inflammation while continuing the CART and treating the underlying OI.
Okay, and the second complication?
HIV-associated neurocognitive disorder, often called HAND or HADC. This happens when HIV directly affects the central nervous system. It can cause a range of problems, from subtle cognitive slowing and memory issues to motor problems, behavioral changes, and even severe dementia.
So assessing mental status and gait is really important.
Absolutely vital throughout the course of the disease.
Okay, shifting to collaborative care. Nutrition seems key.
Definitely. Wasting syndrome can be a major issue. So we emphasize a high-calorie, high-protein diet, often with small, frequent meals. Getting a registered dietitian nutritionist, an RDN, involved is usually essential.
And mouth care?
Crucial, especially if they develop mucositis, painful inflammation of the mouth lining, which is common, gentle care with a soft toothbrush, maybe using sodium bicarbonate rinses, can help soothe it and prevent secondary infections.
What about activity?
There's strong evidence-based practice here. Supervised exercise programs combining aerobic and resistance training show consistently better improvements in functional capacity, muscle strength, and quality of life compared to just telling patients to exercise on their own.
So nurses can play a big role in coordinating or even leading these supervised programs.
A huge role. It makes a real difference. ##B. Concepts of care for patients with infection, Chapter 21.
Okay, let's broaden the lens now from HIV specifically to the general concepts of infection control and care, which ties right back into our earlier discussion on inflammation and especially the risks for older adults.
Right. Who's most susceptible to infection in general? The risk factors are pretty clear.
Yeah.
Older age is a big one, having chronic illnesses like diabetes, undergoing invasive procedures.
Like having a urinary catheter, CAUDIs are huge.
Exactly. Catheter-associated urinary tract infections. Also, malnutrition weakens defenses, and certainly anyone with decreased immunity, maybe from taking chronic steroids or undergoing chemotherapy.
In the hospital or healthcare setting, controlling transmission is everything. We talked about reservoir.
Yeah, they can be animate people, patients, staff, carriers, or inanimate contaminated equipment, bed rails. Even cell phones are notorious.
That's the #1 way infections spread in healthcare.
Still the hands of healthcare workers. It seems basic, but it's fundamental.
So, hand hygiene. What are the key rules there?
Rule 1 is, do it. But the specifics matter. Alcohol-based hand rubs, APHRs, are great for most situations. They're fast and effective. However,
There's a big but.
a huge but. If your hands are visibly soiled, or if you're dealing with a patient who has or might have an infection caused by a spore-forming organism, particularly Clostridium difficile C. diff,
Then alcohol doesn't cut it.
absolutely not. ABHRs are completely ineffective against C. diff spores. In those cases, you must wash your hands vigorously with soap and water, friction helps physically remove the spores.
That's a critical safety point. Okay, beyond standard hand hygiene, we use transmission-based precautions for specific bugs. Let's start with airborne.
Airborne precautions are needed for microbes that spread on tiny droplet nuclei that can remain suspended in the air for long periods. Think TB, measles, chickenpox. This requires placing the patient in an AIR, an airborne infection isolation room.
Which has special ventilation.
Right. It must have negative air pressure, meaning air flows into the room from the hallway, and the contaminated air from the room is exhausted directly outside or filtered before recirculation. This prevents the infectious particles from escaping the room.
And what do staff wear?
Anyone entering the room must wear respiratory protection, either a fit-tested N95 respirator or a PAPR, a powered air purifying respirator.
Okay, that's airborne. What about contact precautions?
Contact precautions are used for germs spread by direct contact with the patient or their environment. This is crucial for multi-drug-resistant organisms, MDROs like MRSA, methicillin-resistant Staph aureus, VRE, vancomycin-resistant Enterococci, CRE, carbapenem-resistant Enterobacteriaceae,
And C. diff.
and definitely C. diff. For contact precautions, the patient needs a private room, or they can be cohorted with someone else infected with the same organism. Anyone entering the room must put on a gown and gloves before going in and take them off before leaving.
And there's an action alert here about preventing these MDROs, especially CRE, from even taking hold, right?
Yes, a really important one. Using chlorhexidine gluconate, or CHG, for daily bathing, often with wipes, usually a 2% solution has been shown to significantly reduce skin colonization with MDROs in high-risk patients.
Who counts as high risk?
Typically patients in intensive care units, those transferred from nursing homes, or anyone with invasive devices like central lines or ventilators. It's a key preventative strategy.
Okay, assessment for infection. Systemically, we look for
Fever, usually defined as over 101 degrees Fahrenheit or 38.3 Celsius. Chills, malaise, feeling generally unwell, maybe tachycardia. And lab-wise, leukocytosis and elevated white blood cell count.
often with that left shift we talked about earlier, signaling immature neutrophils.
Exactly. But again, we have to circle back to the older adult.
Their presentation can be different.
Dramatically different. Remember their lower baseline temperature. For them, a fever might only be 99 degrees Fahrenheit, 37.2 Celsius. You must prioritize assessing for those non-specific signs. Acute confusion, increased restlessness, maybe incontinence, dehydration, those might be your only clues to a serious infection.
Got it. And managing fever.
Well, antipyretics like acetaminophen can make the patient feel better, but remember, they can mask the fever pattern, which might obscure how the disease is progressing. So use them judiciously.
And a specific safety point about fans.
Right. Especially in hospitals, avoid using portable fans in patient rooms. They can potentially disperse airborne or droplet pathogens, and critically, they can disrupt the carefully controlled negative air pressure in an AIR if the patient is on airborne precautions.
Makes sense. And the big danger if infection isn't treated effectively.
It progresses. A local infection can spread into the bloodstream that's bacteremia or septicemia, and from there, it can rapidly spiral into septic shock, a life-threatening condition with widespread inflammation and organ failure. We see that covered in more detail later, like in Chapter 34, Context.
Okay, complete shift now. We've covered immune failure or reduction. Now let's tackle the second major category. When the immune system is excessive or acts inappropriately. This lands us in the realm of hypersensitivity and autoimmunity. #LA. Hypersensitivity, allergy reaction.
Right. Hypersensitivity or allergy is basically an over-the-top inflammatory response. The immune system reacts excessively to an antigen, or we call it an allergen in this context, that it really should just ignore.
And this can range from
Annoying like seasonal hay fever, all the way to potentially fatal like anaphylaxis or severe angioedema. The most common and often the most dangerous type is type I, rapid hypersensitivity, also known as atopic allergy.
Okay, type I. What's the mechanism? How does it work?
It all revolves around a specific antibody, IgE. The first time a susceptible person is exposed to the allergen, say, peanut protein, their body gets sensitized. It produces large amounts of IgE antibodies specifically targeted against that peanut protein.
So first, exposure primes the system.
Exactly. That IgE then acts like little flags or triggers. They coat the surface of mast cells and basophils, those cells loaded with histamine we talked about earlier. They just sit there waiting.
Waiting for the next exposure.
Right. When the person encounters that same allergen, again, eats peanuts, gets stung by a bee, the allergen binds to those IgE antibodies sitting on the mast cells. This binding is the trigger. It causes the mast cells to immediately degranulate,
Dump their contents.
dump massive amounts of histamine and other inflammatory mediators straight into the bloodstream and tissues. This happens very quickly.
And that rapid release causes the immediate dramatic symptoms.
Precisely. Things like hives, itching, swelling, bronchospasm, and allergic asthma, or the life-threatening systemic reactions. Think peanuts, latex, bee stings, certain drugs.
Which brings us to the ultimate type I emergency, anaphylaxis.
Yes, anaphylaxis is a rapid, systemic, widespread type I reaction. It's not localized. It involves blood vessels everywhere and the smooth muscle in the bronchioles all at the same time.
What happens physiologically?
You get massive, widespread vasodilation. Blood vessels relax and widen everywhere. This causes a sudden, drastic drop in blood pressure and decreases cardiac output. Fluid leaks out of the leaky vessels into the tissues, causing swelling. And at the same time, you get profound bronchoconstriction. The airways clamp down.
And this can happen incredibly fast.
Within minutes of exposure, it's a true medical emergency.
How's it diagnosed? You don't have time for labs.
Absolutely not. The diagnosis is clinical, based on recognizing a pattern of signs and symptoms. There are specific criteria, but essentially, a patient is likely having anaphylaxis if any one of three things happens quickly after a likely allergen exposure. 1. Acute onset involving the skin or mucous membranes, like hives, itching, swollen lip stum, and either respiratory compromise, wheezing, shortness of breath, or hypotension signs of end organ damage.
Okay, skin mucosa plus respiratory or low BP.
2. Rapid onset of two or more of the following after exposure: skin mucosal symptoms, respiratory compromise, hypotension, or persistent GI symptoms like cramping or vomiting.
Got it. Or third.
Third criterion is simply development of hypotension, systolic BT below 90 mmHg, or a drop of more than 30% from their baseline, soon after exposure to a known allergen for that patient. Any one of those criteria met means act now.
Which brings us to the critical rescue interventions. Time is absolutely critical here.
It's everything. Delay in giving epinephrine is the single biggest factor linked to fatal outcomes. So, first priority, recognize it's happening, immediately call for help, the rapid response team or code team, and assess and secure the airway. Gas exchange is always the top priority.
Okay, airway first. What if you suspect an IV drug caused it?
Stop the infusion immediately, but, and this is critical, do not pull out the IV excess. You need that line. Change the IV tubing right away to get rid of any residual drug, and hang normal saline to keep the vein open and provide volume.
And then the key medication.
Epinephrine. Administer it immediately. It's the first-line drug, no question, usually given intramuscularly, IM, in the thigh, because that provides the fastest absorption in this emergency situation. And you may need to repeat the dose every 5 to 15 minutes if symptoms persist or worsen.
Why epinephrine? What does it do?
It's the direct countermeasure. It causes vasoconstriction, helping to raise that dangerously low blood pressure. It increases the force of cardiac contraction. And most importantly, it's a potent bronchodilator. It rapidly opens up those constricted airways.
Okay, airway, stop trigger if possible, give epi-IM. What else?
Position the patient. Generally, elevate the head of the bed to about 45 degrees to help with breathing, unless they're severely hypotensive. If their BP is crashing, lay them flat, maybe even elevate their legs to maximize blood flow to the brain.
And oxygen.
Absolutely. High flow oxygen, 90 to 100%, via a non-rebreather mask to support oxygenation.
Wow, okay, intense sequence. What about people who know they have severe allergies? EpiPens.
Yes, patient education on auto-injectors like the EpiPen is vital. They need hands-on training practice with a trainer device. They need to understand. Use it immediately when symptoms start. Don't wait. Use it before calling 911.
Carry 2.
Always carry 2 in case the first dose isn't enough or there's malfunction. And they need to know how to store them properly, protect them from light and extreme temperatures. Check expiration dates.
Got it. One more related condition, angioedema.
Right. Angioedema is a similar type of deep tissue swelling, but it's often more localized, typically affecting the lips, tongue, face, larynx, neck, sometimes hands, feet, or GI tract.
Can it be life-threatening?
Definitely. If it involves the airway, swelling of the larynx can cause complete obstruction. While sometimes it's part of an allergic reaction, a really key trigger nurses need to watch for is ACE inhibitor drugs.
The blood pressure meds ending in a prol.
Exactly. Lisinopril and enalapril, etc. Angioedema is a known, potentially severe side effect. And the tricky part is, it doesn't necessarily happen when they first start the drug. It can occur months, even years after they've been taking it, seemingly without issue.
So you always have to consider it if someone on an ACE inhibitor develops sudden facial or throat swelling.
Absolutely. And airway protection is the immediate priority if it occurs.
Okay, moving from hypersensitivity to the broader category of autoimmunity.
Hmm.
This is where that concept of self-tolerance completely breaks down.
Right. In conditions like systemic lupus erythematosus, or SLE, what seems to happen in genetically susceptible people is that their T regulator cells, the cells that normally help keep the immune response in check and maintain self-tolerance, are either reduced in number or don't function properly.
So the don't attack self signal fails.
Exactly. That biometric scanner is broken. The immune system loses its ability to differentiate self from non-self, and it starts producing antibodies directed against the body's own tissues and cells.
And in SLE, this often manifests as what type of reaction?
SLE is typically considered a type 3 hypersensitivity reaction. Remember, type I was IgE mediated. Type 3 involves immune complexes,
Mimi.
meaning these autoantibodies bind to self-antigens, like pieces of DNA or proteins from damaged cells, forming clumps called immune complexes. These complexes circulate in the bloodstream.
And they cause problems where they land.
Precisely. They're too large to stay dissolved, so they get deposited or trapped in the small blood vessels and basement membranes of various tissues, particularly the skin, the joints, the kidneys, the heart, the lungs, the brain, pretty much anywhere.
And what happens when they get trapped?
They trigger inflammation. They activate complement and attract neutrophils and macrophages to the site. This results in chronic systemic inflammation of the blood vessels themselves, a condition called vasculitis.
So SLE is fundamentally a disease of blood vessel inflammation.
In many ways, yes. That widespread vasculitis compromises blood flow, leading to reduced perfusion and chronic damage in whatever organ system is affected.
Which explains why it's called the great imitator.
Exactly. Because it can affect almost any organ system, the symptoms can be incredibly varied and often vague, especially early on. It's typically chronic and progressive, characterized by periods of relative remission alternating with acute flares or exacerbations.
And given this attack on blood vessels, what are the biggest long-term threats?
The consequences of that chronic vasculitis and organ damage. The most common causes of death in patients with SLE are related to chronic kidney disease, from immune complex deposition in the glomeruli, causing lupus nephritis, and cardiovascular impairment, accelerated atherosclerosis, heart failure, stroke, often linked to the chronic inflammation and steroid use. Managing SLE is really about managing this chronic inflammatory assault on the vascular system.
Okay, what does a classic flare look like?
While it varies, some common features during a flare include fever, profound fatigue, that characteristic butterfly rash, malar rash, across the cheeks and nose, possibly discoid lesions, coin-shaped scarring lesions, often on sun-exposed areas, and joint involvement, painful, swollen joints, arthralgias or arthritis, affect about 90% of patients at some point.
And who tends to get SLE?
There's a very strong gender and ethnic predisposition. It occurs about 10 times more frequently in women than in men, often striking during childbearing years, typically ages 30 to 44. This strongly suggests hormones, particularly estrogen, play a role.
And ethnicity.
Incidence is significantly higher in African Americans, Hispanic Americans, and Asian Americans compared to Caucasians. When assessing a patient, especially a woman in that age group presenting with vague chronic symptoms, you have to keep SLE on the differential.
What kind of vague symptoms?
Things like persistent, debilitating fatigue that's out of proportion to activity, recurring low-grade fevers with no obvious source, persistent joint aches or muscle pain, maybe some hair loss. It often takes time to piece the puzzle together.
Management sounds complex. What are the main strategies?
It's definitely multifaceted. Pharmacologic therapy is key, aimed at reducing inflammation and suppressing that overactive immune response. The cornerstone for managing flares is still corticosteroids, like prednisone.
Powerful anti-inflammatories, but lots of side effects.
Tons of side effects with long-term use: weight gain, mood changes, increased infection risk, osteoporosis, hyperglycemia, GI ulcers, but they are very effective at controlling acute inflammation. The critical safety alert here, though, relates to stopping them.
Never stop abruptly.
Never stop corticosteroids abruptly, especially after prolonged use. The body stops making its own cortisol when on external steroids. Stopping suddenly can cause a life-threatening adrenal crisis. The dose must always be tapered down slowly under medical guidance.
Okay. Besides steroids?
Anti-malarial drugs, specifically hydroxychloroquine, Plaquenil, are used very commonly, often long-term. They have immunomodulating effects, help control skin and joint symptoms, and may even have some anti-clotting benefits.
But hydroxychloroquine has a major safety issue too, right?
Yes, another huge safety alert. The major concern is retinal toxicity. The drug can accumulate in the retina and cause irreversible damage, leading to vision loss. This requires strict monitoring.
Palvin.
Patients need a baseline eye exam before starting, and then follow-up eye exams, including specialized tests like visual field testing, every 6 months while on the drug. Patient education about reporting any visual changes immediately is crucial.
What about newer drugs?
We now have monoclonal antibodies like belimumab, Benlysta. These are more targeted therapies that block specific cytokines or B-cell activity involved in the lupus process. They're usually given IV or subcutaneously.
Any specific risks with those?
Because they are biologic agents, there's always a risk of infusion reactions or severe hypersensitivity reactions. Patients need to be monitored closely during and after administration, especially with the first few doses. They also increase infection risk.
Okay, drugs are one part. What about lifestyle and safety management?
This is absolutely critical for managing SLE long-term and preventing flares, and there's a huge action alert regarding UV light.
Sunlight is a major trigger.
A massive trigger for systemic flares in many SLE patients. Why? Because UV radiation damages skin cells. When those cells die, they release their nuclear contents, including DNA. In someone with SLE, their immune system sees this self-DNA floating around as a foreign antigen.
And launches an attack.
Exactly. It kicks off that whole autoantibody production and immune complex formation, leading to a systemic inflammatory flare.
So sun protection is non-negotiable.
Absolutely non-negotiable. Patients must be taught to strictly avoid prolonged sun exposure, especially midday sun. Use broad-spectrum sunscreen with SPF 30 or higher. Wear long sleeves, wide-brimmed hats, seek shade. It's a cornerstone of management.
What about fatigue?
Fatigue is often profound and chronic in SLE. Patients need help accepting it and developing coping strategies, prioritizing activities, pacing themselves, ensuring good sleep hygiene. It's not just being tired.
And long term.
Because of those high risks of kidney and cardiovascular disease being the main causes of death, vigilant long-term monitoring is essential. This means regular checks of kidney function, urinalysis, creatinine, blood pressure, cholesterol levels, and screening for cardiovascular risk factors, often annually or even more frequently if there's active disease.
All right, we've journeyed through insufficient immunity and excessive immunity. Our final section tackles the third major category, the catastrophic failure of normal checks and balances, the loss of cellular regulation that results in cancer, #tag EA. Concepts of Cancer Development, Chapter 19.
Right. Cancer or malignancy at its absolute core is about uncontrolled, abnormal cell growth that serves no useful purpose. When you compare cancer cells to normal cells or even to benign tumor cells, there are some key differences.
What stands out?
Malignant cells often show anaplasia. They lose the specific appearance and specialized function of their parent cell. They look weird, undifferentiated. They also lose contact inhibition.
Meaning they don't stop dividing when they bump into each other.
Exactly. Normal cells stop dividing when they form a single layer and touch each other. Cancer cells just keep piling up, forming tumors. And genetically, cancer cells almost always exhibit aneuploidy.
Abnormal chromosome numbers.
Right. Abnormal numbers or structure of chromosomes. Benign tumor cells, while growing inappropriately, usually maintain normal chromosome numbers. They're euploid. That difference in genetic stability is a hallmark.
Okay. How does a normal cell actually become cancerous? What's the process?
It's usually a multi-step process called carcinogenesis or malignant transformation. It typically involves 4 stages. First is initiation.
The first hit.
Exactly. This is where a carcinogen-like radiation, certain chemicals or viruses, causes irreversible damage to the cell's DNA. But this one hit isn't usually enough to cause cancer on its own.
What's next?
Promotion. This is where other substances or conditions, promoters, which may not be carcinogenic themselves, like hormones or chronic inflammation, enhance the growth of that initiated cell. This stage is often reversible if the promoter is removed.
Then it gets worse.
Then comes progression. This involves continued changes in the cancer cells, making them grow faster, become more malignant, develop their own blood supply, angiogenesis, and finally, metastasis.
The ability to spread.
Right. This is the defining characteristic of malignancy. The ability of cancer cells to break away from the primary tumor, invade surrounding tissues, enter the bloodstream or lymphatics, travel to distant sites, and establish new secondary tumors.
What's happening at the genetic level during all this?
2 main types of genes are usually involved. Every cell has proto-oncogenes, which are like the gas pedal, normally regulating controlled cell growth and division. When these get damaged or mutated by carcinogens, they can become oncogenes.
The gas pedal gets stuck down.
Exactly. Oncogenes are overactive, leading to uncontrolled accelerated cell division. On the flip side, every cell also has suppressor genes. These are like the brakes.
Their job is to limit growth.
Right. They normally inhibit cell division, repair DNA damage, or trigger cell death, apoptosis, if damage is too severe. When suppressor genes get damaged or mutated, the brakes fail.
So gas pedal stuck down, brakes failed, recipe for uncontrolled growth.
That's a great analogy. It's often a combination of oncogene activation and suppressor gene inactivation that drives cancer development.
Okay, let's talk risk factors. What's the biggest one?
Hands down, the single most important risk factor for cancer is age. As we get older, our immune system function naturally declines, immunosurveillance weakens, and we have more cumulative exposure to carcinogens over our lifetime.
Makes sense. What about immunity itself?
Reduced immunity is definitely a major risk factor. We see much higher rates of certain cancers in people with conditions like HIV/AIDS, where the immune system is severely compromised. Also, organ transplant recipients who are on lifelong immunosuppressive drugs to prevent rejection have a significantly increased risk of cancer.
And lifestyle or environmental factors?
Huge contributors. Tobacco use is linked to about 30% of all cancer deaths. It's implicated in cancers of the lung, mouth, throat, esophagus, bladder, kidney, pancreas, cervix. The list goes on. We see high rates in veterans due to past smoking prevalence.
Diet.
Diet plays a role too. Diets high in animal fat and low in fiber are linked to colon cancer. Preservatives like nitrates and processed meats can be carcinogenic. Excessive alcohol intake increases risk for several cancers, including liver, esophageal, and head and neck cancers.
So prevention strategies fall into categories.
Right. Primary prevention is about avoiding exposure to known carcinogens in the first place. So don't smoke, use sunscreen to avoid excessive UV radiation, limit alcohol, eat a healthy diet, maintain a healthy weight, and get vaccinated against cancer-causing viruses like HPV.
And secondary prevention.
That's about early detection through screening when the cancer is potentially more treatable or curable. This includes things like regular mammograms, pap smears, colonoscopies, fecal occult blood testing, and crucially, it includes teaching people to recognize the 7 warning signs of cancer.
The CAUTION acronym. Let's quickly go through them, maybe emphasizing what the change really means for a patient.
Good idea. C is for changes in bowel or bladder habits. Is this a new persistent constipation, diarrhea, or change in stool shape? Is there new urinary frequency, urgency, or blood in the urine?
A is for a sore that does not heal. Especially think mouth sores for smokers, drinkers, or skin sores that just linger for weeks or months.
U for unusual bleeding or discharge. Bleeding from any body orifice that's not normal, postmenopausal bleeding, rectal bleeding, blood in sputum or urine, unusual vaginal discharge.
T is for thickening or lump. Finding a new lump or thickened area, particularly in the breast or testicles, but really anywhere in the body.
I is for indigestion or difficulty swallowing, persistent heartburn that doesn't respond to usual remedies, or a feeling of food getting stuck, dysphagia.
O for obvious change in a wart or mole. This is key for skin cancer. Look for changes in asymmetry, border irregularity, color variation, diameter larger than 6 millimeters, and evolving appearance, ABCDE.
And N for nagging cough or hoarseness. A cough that lasts more than a few weeks, especially in a smoker, or persistent hoarseness.
Knowing these signs and seeking medical attention early is so critical.
It can absolutely be life-saving. Early detection often means the cancer is still localized and potentially curable. #B. Concepts of care for patients with cancer, Chapter 20.
Okay, let's shift now to the practicalities, the concepts of care for patients with cancer, focusing heavily on the consequences of the disease and its treatment, and especially on safety priorities.
Right. One of the most immediate and universal problems for many cancer patients is impaired immunity and clotting. This usually stems from bone marrow suppression.
Caused by the cancer itself invading the marrow, or more often by the treatment.
Often both, but chemotherapy and radiation are major culprits because they target rapidly dividing cells, and bone marrow stem cells are constantly dividing to produce blood cells.
So this suppression leads to
3 critical problems: anemia, low red blood cells causing fatigue, shortness of breath; neutropenia, critically low neutrophils leading to a very high risk of infection; and thrombocytopenia, low platelets leading to a high risk of bleeding. Managing these is a cornerstone of cancer care.
What about nerve damage?
That's another major issue, particularly chemotherapy-induced peripheral neuropathy, or CIPN. Certain chemo drugs are toxic to peripheral nerves.
What does CIPN look like?
It typically starts in the hands and feet, loss of sensation, numbness, tingling, burning pain, feeling like walking on pins and needles. It can affect balance and gait, increasing fall risk. It can also cause muscle weakness and neuropathic pain.
And it can be severe.
It can be debilitating, and importantly, CIPN is often dose-limiting. That means the chemotherapy dose might have to be reduced or the drug stopped altogether if the neuropathy becomes too severe, potentially compromising the effectiveness of the cancer treatment. Early assessment and management are key.
Okay, what about cancer spreading to bones?
Bone metastasis is common with many cancers, like breast, prostate, lung. This weakens the bone, leading to significant pain and a high risk of pathological fractures occurring with little or no trauma.
And if it affects the spine?
Metastasis to the vertebrae can lead to spinal cord compression, SCC. This is a true oncologic emergency. As the tumor grows, it presses on the spinal cord or the nerve roots exiting the cord.
We'll come back to the signs of SCC, but it requires immediate intervention.
Absolutely. Delay can result in permanent paralysis.
Okay, let's drill down into treatment safety, starting with radiation therapy. What about seal implants, like brachytherapy?
Right. This is where a radioactive source is placed directly inside or very close to the tumor. Common examples are radioactive seeds for prostate cancer or implants for cervical cancer. With sealed sources, the radioactive material is encapsulated.
But the patient emits radiation.
Yes. The patient themselves becomes radioactive for a period of time. This completely changes the care environment. Strict safety protocols are essential to protect staff, visitors, and other patients.
What are the key rules?
The patient must be in a private room. A clear sign saying, "Caution, radioactive material," must be posted on the door. All staff providing direct care must wear a dosimeter badge.
What does the dosimeter do?
It measures the cumulative radiation dose the staff member receives over time. Importantly, it offers zero protection. It's just a monitoring device.
So how do staff protect themselves?
Use lead aprons when providing close care. And critically, always face the radioactive source when wearing the apron, as it only shields the front. Minimize time spent in the room, maximize distance whenever possible. Radiation exposure decreases rapidly with distance, the inverse square law.
What about visitors?
Visitors must be strictly limited, usually to about 30 minutes per day, and they must maintain a distance of at least 6 feet from the patient. Pregnant women and children under 16 should not visit at all.
Okay, that's for sealed sources. Is the patient's excreta radioactive?
This is a crucial distinction. With sealed implants, the radioactive material is contained. Therefore, the patient's urine, feces, sweat, etc. are not radioactive. That's different from unsealed systemic radiation therapy.
Got it. What about external beam radiation?
With external radiation, the patient lies on a table and a machine directs beams of radiation at the tumor from outside the body. The patient is not radioactive after the treatment session.
But there are side effects.
Yes. Systemic side effects include profound, often debilitating fatigue, and potentially bone marrow suppression if large areas of bone marrow are within the radiation field, leading to reduced immunity. Locally, skin reactions are common, and a significant long-term risk is that radiation can damage the DNA of normal cells in the treatment area, increasing the risk of developing secondary cancers years or decades later.
Okay, let's move to chemotherapy. Systemic treatment hits rapidly dividing cells everywhere.
Exactly. That's why we see the classic side effects: hair loss, alopecia, nausea and vomiting, diarrhea, mucositis, sore mouth, and that critical bone marrow suppression.
We need to define the nadir.
Yes. The nadir is the point in time after a chemotherapy cycle when the bone marrow activity and blood cell counts, particularly white blood cells, neutrophils, and platelets, are at their absolute lowest.
When does it usually occur?
It varies depending on the specific drugs used, but typically it's around 7 to 10 days after treatment administration.
And why is knowing the nadir so important?
Because this window represents the period of greatest risk for the patient. They are most vulnerable to life-threatening infection due to severe neutropenia and at highest risk for serious bleeding due to thrombocytopenia. All precautions must be heightened during the nadir.
Okay, another chemo risk, extravasation.
This is a devastating complication. It happens when a vesicant chemotherapy drug, one that can cause severe tissue damage, accidentally leaks out of the vein and into the surrounding subcutaneous tissue during 5E infusion.
What does it cause?
Severe local tissue destruction, pain, burning, swelling, blistering, and potentially deep necrosis requiring surgical debridement or even amputation. It's an emergency.
How is it prevented?
Prevention is key. Using central venous access devices, like ports or PICC lines, for vesicant infusions is much safer than peripheral IVs. If a peripheral IV must be used, nurses need to meticulously monitor the site constantly during the infusion for any signs of swelling, redness, pain, or lack of blood return. If extravasation is suspected, the infusion must be stopped immediately, and specific protocols followed, which may involve aspirating residual drug and administering an antidote.
What about oral chemotherapy? Seems safer.
It's becoming much more common, and while it avoids IV risks, it brings its own set of safety challenges, especially since patients take it at home.
Like what?
Handling safety is crucial. These are still hazardous drugs. Patients and family members need education. Store these meds separately from all other medications. Avoid touching the pills directly. Use the cap of the bottle to tip the pill into a small cup, or wear designated gloves if crushing or splitting is required, though often discouraged. Dispose of empty bottles properly.
And adherence.
Adherence is just as critical as with IV chemo. Missing doses can compromise treatment effectiveness. Patients also need clear instructions on managing side effects at home and knowing exactly when to call their provider. Signs of infection, severe nausea, vomiting, etc. It requires intensive patient education.
Okay, let's focus on managing those key side effects from bone marrow suppression. First, neutropenia and infection risk.
The absolute #1 priority for a neutropenic patient is protection from infection. Remember, their defenses are down. There's a crucial action alert. Any temperature elevation over 100.4 degrees F, 38 degrees C, in a neutropenic patient must be considered a potential emergency and reported immediately.
Why such a low threshold?
Because, again, they may not be able to mount a robust inflammatory response. They might not develop pus at an infection site. The WBC count won't necessarily shoot up, and they might not even get a high fever. That slight temperature elevation could be the only sign of a potentially life-threatening sepsis.
So what are the best practices for protecting them?
Strict hand washing by everyone entering the room is paramount. Place the patient in a private room, limit the number of staff and visitors entering, monitor vital signs frequently, at least every 4 hours, specifically looking for subtle temp changes or tachycardia. Use strict aseptic technique for all invasive procedures. IV starts, catheter care, wound care. Avoid fresh flowers or uncooked foods that might harbor bacteria or fungi.
Okay, that's infection. What about thrombocytopenia and bleeding risk?
When platelet counts drop significantly, the priority shifts to preventing trauma and bleeding. The risk of spontaneous, uncontrollable bleeding becomes extremely high if the platelet count falls below 20,000 millimeters 3, though precautions often start at 50,000.
So best practices for bleeding precautions.
Create a safe environment. Use an electric shaver instead of a razor. Use a soft-bristled toothbrush and avoid dental floss if counts are very low. Advise against any contact sports or activities with high fall risk. Avoid aspirin and other NSAIDs like ibuprofen, naproxen as they interfere with platelet function. If possible, avoid invasive procedures like intramuscular injections, enemas, or rectal suppository temperature measurements, as these can cause bleeding. Pad bed rails if necessary. Monitor constantly for any signs of bleeding, petechiae, ecchymosis, nosebleeds, blood in urine or stool, bleeding gums.
Meticulous, gentle care.
Absolutely. Every interaction needs to minimize trauma potential.
Let's briefly touch on targeted therapy. How is it different?
Targeted therapies are a newer class of cancer drugs designed to interfere with specific molecules or pathways involved in cancer cell growth and survival, rather than just killing all rapidly dividing cells like traditional chemo. They often target specific mutations or proteins like EGFR, epidermal growth factor receptor, or VEGF, vascular endothelial growth factor, or specific enzymes like tyrosine kinases, TKIs.
Fewer systemic side effects.
Generally, yes, they tend to cause less bone marrow suppression and hair loss than traditional chemo. However, they have their own unique side effect profiles, which can be significant.
Examples.
For instance, EGFR inhibitors, used for lung colorectal cancers, commonly cause a very specific, often severe acneiform skin rash. Managing this rash is key to keeping patients on therapy. VEGF inhibitors, which block tumor blood vessel growth, often cause hypertension and can impair wound healing. Each targeted drug class has its own set of potential toxicities that nurses need to know and monitor for.
Got it. Finally, let's highlight those oncologic emergencies. Early detection is critical. We mentioned spinal cord compression, SEC, earlier.
Yes, the absolute key here is recognizing the early signs, because treatment needs to happen immediately to prevent permanent paralysis. Don't just dismiss back pain in a cancer patient, especially if it's new, worsening, or different in character.
What are the red flags beyond pain?
Look for new onset neurological deficits, numbness, tingling, or weakness, particularly in the legs, often bilateral. An unsteady gait, difficulty walking, changes in sensation, decreased deep tendon reflexes, and late, ominous signs are loss of bowel or bladder control, incontinence or retention. Any of these warrants urgent investigation, usually with an MRI, and immediate treatment.
What's the treatment?
Usually high-dose corticosteroids, like dexamethasone, started immediately to reduce spinal cord edema, followed by definitive treatment like radiation therapy to the site, or sometimes surgery to decompress the cord.
Okay, SEC. What's another common emergency?
Hypercalcemia, high calcium levels in the blood. This is a common metabolic emergency, especially in patients with cancers that metastasize to bone, like breast, lung, multiple myeloma, or certain cancers that produce parathyroid hormone-related protein.
How does it happen?
The cancer activity in the bone causes excessive breakdown, resorption, releasing large amounts of calcium into the bloodstream faster than the kidneys can excrete it.
What are the symptoms? They can be vague, right?
Yeah, very vague initially. Fatigue, lethargy, loss of appetite, nausea, vomiting, constipation, increased thirst and urination, confusion, even coma in severe cases. It can also cause kidney stones and ECG changes.
How is it managed?
The cornerstone is aggressive IV hydration with normal saline to dilute the calcium and promote excretion by the kidneys. Loop diuretics might be used cautiously once hydration is restored. Drugs called bisphosphonates, like pimodronate or zoledronic acid, are given IV to inhibit bone resorption and lower calcium levels. Treating the underlying cancer is also key.
Okay, one more major emergency. Tumor lysis syndrome, TLS.
TLS is a potentially lethal complication that happens when a large number of cancer cells are killed off rapidly, often after the initiation of effective chemotherapy or radiation, especially for bulky, fast-growing cancers like leukemias or lymphomas.
What happens when the cells die?
They burst open, and release massive amounts of their intracellular contents into the bloodstream all at once. This includes potassium, phosphate, and nucleic acids, which break down into uric acid.
And the body can't handle that flood.
Exactly. The kidneys get overwhelmed trying to excrete it all. This leads to a cascade of life-threatening metabolic imbalances. Severe hyperkalemia, risk of cardiac arrhythmias and arrest, hyperphosphatemia, which causes secondary hypocalcemia, hyperuricemia, high humic acid, which can crystallize in the kidney tubules causing obstruction, and ultimately acute kidney injury, AKI.
So prevention is key here too.
Prevention and anticipation are everything for TLS. Patients at high risk, those with large tumor burdens, high cell turnover rates, need prophylactic measures started before treatment begins. This includes aggressive IV hydration to maintain high urine output and flush the kidneys. They're also given medications like allopurinol to block uric acid production, or sometimes rasburicase, an enzyme that breaks down existing uric acid, to prevent hyperuricemia and subsequent kidney damage. Close monitoring of electrolytes and kidney function is critical during the high-risk period after starting treatment. #tag outro.
Wow. We have definitely covered an immense amount of ground today. We've navigated this really complex spectrum of immune disorders, from the system not doing enough to doing way too much to losing control entirely.
We really looked at that whole continuum. We saw the delicate balance needed for health and then examined those three main points of failure. Insufficient defense, thinking about HIV and systemic infections. Then that inappropriate excess, like life-threatening anaphylaxis or the chronic battle of SLE. And finally, that ultimate loss of control seen in cancer.
And if there's one thread tying all of this together, it seems to be the absolute need for collaborative care and just constant vigilance from the healthcare team.
Absolutely, hypervigilance. Whether it's strictly enforcing that 90% adherence rule for CART and HIV or executing that immediate, precise sequence of actions for anaphylaxis with epinephrine, or maintaining those meticulous infection and bleeding precautions for a cancer patient during their nadir. Patient safety really hinges on early recognition and precise, knowledgeable intervention.
So for you, the listener, the clinician, your role is fundamental. It's using standard precautions universally, yes, but it's also educating patients, empoweringly on self-management, how to use an EpiPen, recognizing those caution signs of cancer, the critical need for sun protection in SLE.
And it's about being that expert assessor who can pick up on the subtle signs, that slight confusion in an older adult that might signal sepsis, or there's new neurological deficits in a patient with bone pain that scream spinal cord compression. You have to connect the dots.
So looking ahead, what's the final thought here? Many of these conditions, HIV, SLE, even many cancers, are becoming chronic, manageable diseases rather than acute death sentences.
That's right. And so the focus increasingly shifts towards long-term quality of life and managing the late effects of treatment. Think about the ongoing impact of things like permanent chemotherapy-induced peripheral neuropathy or the cardiac toxicity that can show up years after certain chemo drugs or radiation.
The next frontier.
It really involves continuing the push for more targeted, personalized therapies treatments that are just as effective against the disease but have fewer damaging side effects, minimizing those long-term morbidities, and truly improving survivorship, not just survival rates. That's where research is heading, and it's crucial for the future of care in all these areas.
A truly critical, incredibly complex, but essential body of knowledge for anyone in healthcare. That's all the time we have for this deep dive.